Welcome again to the clinical case scenario series. Today is clinical case scenario number 3. Today's clinical patient is a 68-year-old man who's referred by his general practitioner with a 6-week history of lethargy and breathlessness on walking. There is no history of pain or fever. He has lost appetite and has lost about 12 kg in the last 2 months. He reports no rectal bleeding or change in bowel habit. His father died at the age of 58 years from a colonic tumor. He is otherwise well and not on any regular medication. His GP referred him to the colorectal clinic as he was concerned about his blood results and his strong family history of colorectal cancer. An esophageal gastroduodenostomy or OGDS done has been previously requested by the GP and was normal. On examination, he was afebrile, his conjunctiva are pale and he looks cachectic. There is no jaundice or palpable lymphadenopathy. The chest is clear and the heart sounds are normal. Examination of the abdomen reveals a fullness in the right ilia fossa. There was no tenderness or guarding. There is also no associated hepatomegaly and no ascites. Digital rectal examination is normal. These are the blood investigations done for the patient. Please go through these investigations and decide what are the abnormalities that you detect in this. These are the CT scan and the colonoscopy pictures taken for the patient. Please comment on your findings. Now we come to the questions. What does the full blood picture show in this patient? How should the anemia be investigated in him? What is the most likely diagnosis in this patient? What further investigations are required for this patient? A CT scan and a colonoscopy were done and the results are shown. Please comment on the findings. What is the appropriate treatment for this patient? Okay, these are the questions. Can you please go through these questions and answer them before proceeding on to discuss the case? Okay, I'm sure you have answered those questions. Now let's analyze the case and see what we find. Okay, this is the history. The red highlighted in red are those pertinent factors that are important in this patient, which are summarized in the next slide. Okay, so 68-year-old man, 6-week history of lethargy, breathless on exertion, loss of weight of 12 kilos in 2 months, and father has died of carcinoma of the colon, and the blood results were interpreted by the GP and referred to a colorectal surgeon. Okay, and the negative symptoms were OGDS was normal, suggesting unlikely to have any upper GI causes for his problem. He does not have fever, meaning that it may not be an inflammatory or infective cause for his symptoms and the mass. There's no PR bleeding, which suggests that unlikely to be hemorrhoids or colorectal lesions like cancer. Also, there are no bowel habits changes, indicating that unlikely to be a left-sided abdominal colonic problem. And there's no medication listed as a cause for erosive gastritis and ulcer. So, what will be the inferences from the history? The clinical problem that infer from this history Instead, a 68-year-old man referred to the colorectal clinic with suspicion of a colorectal problem, with generalized debility and exertional dyspnea, okay, loss of weight, and this going on for the last 6 weeks. So the possible causes of this could be some form of chronic gastrointestinal bleeding, peptic ulcer, polyp, or some form of cancer, among which carcinoma of the colon is the most likely. Next is carcinoma of the stomach, and also patient is having dyspnea on exertional dyspnea. She had to be ruled out cardiac problems, although he denies having any history of heart disease, and some other causes of chronic anemia. Now on examination again, the important points will be highlighted from this examination. Is highlighted will summarize here. Positive sign, cachectic, pallor, and fullness in the right lower quadrant, suggestive of a mass. Negative signs, no fever, no jaundice, no tenderness and guarding, no ascites, and rectal examination is normal. So, from the physical examination, the problem that we derive is the patient, an elderly patient with anemia and loss of weight with a mass at the right ilia fossa. The possible causes after the physical examination can be carcinoma of the ascending colon or cecum, appendicular mass, or chronic inflammatory bowel disease such as Crohn's disease, especially involving the terminal ileum. So we summarize the patient. Clinical summary is a 68-year-old man with a strong family history of colon cancer, presenting with 6 weeks history of effects of anemia, side complications of anemia, loss of weight, and loss of appetite. And then there is a vague mass in the right ilia fossa, which is non-tender and there's no guarding. Also, there's no bleeding PR and the rectal examination was normal. So with this clinical summary, we come to the possible diagnosis in this patient. As listed here, carcinoma cecum or ascending colon, appendicular mass, lymphoma, abdominal lymphoma, especially lymph nodes, mesenteric adenitis, terminal ileitis, and Crohn's disease. So with this analysis, clinical analysis, and with the investigations, we come to a final diagnosis of carcinoma of the cecum with anemia. Now, we go through the questions and answers again. What does the blood test reveal? It reveals anemia, okay? This reveals chronic anemia. How should the anemia be investigated? By doing a serum creatinine, ferritin, peripheral blood film looking for microcytosis and hypochromia, and occult blood and fecal immunochemical testing. Okay, these will confirm iron deficiency anemia and the possible source as the intestine, large intestine. Question B, what is the most likely diagnosis in this case? Carcinoma of the cecum with iron deficiency anemia. Question C, what further investigations are required for this patient? As is done in this patient, you must do a CEA, carcinoembryonic antigen, chest X-ray, CT abdomen, and colonoscopy with biopsy. Question D, the CT scan of the abdomen of the patient is shown. What is the finding? There's a hyperdense mass in the region of the right ilia fossa with well-defined borders. Colonoscopy then revealed the lesion as shown in the picture. Describe your findings. It's a fungating growth in the cecum which is ulcerated and bleeding. So with your final diagnosis, what treatment is appropriate for this patient? Right hemicolectomy and primary ileocholic anastomosis, followed by chemotherapy, adjuvant chemotherapy. So these are the questions for the clinical scenario that we have discussed. What are the key points to take home from today's lesson on carcinoma of the right colon and cecum? The key symptoms of colorectal cancer are change in bowel habit and rectal bleeding. As for the right colon and cecal cancer, unexplained chronic anemia and unexplained weight loss are some of the common presenting features of these tumors, and especially so with a mass in the right lower quadrant. Age, family history, and diet are important risk factors for developing these cancers. The gold standard for the diagnosis is colonoscopy with biopsy. Carcinoembryonic antigen, or CEA, is useful in monitoring the treatment efficacy and disease recurrence, not an aid to diagnosis. Surgical resection remains the only definitive cure for tumors of the right colon and cecum. And chemotherapy and immunotherapy may be useful adjuncts to this treatment. So in a patient, especially an elderly woman with unexplained anemia and weight loss, always remember to arrange for a colonoscopy for this patient to rule out carcinoma of the ascending colon and cecum. We come to the end of this discussion of the clinical case scenario of a patient with a mass at the right ilia fossa and features of iron deficiency anemia. Okay, I hope my short discussion would have been of help to you. But as you go back, the important thing to take back home in this case is all patients with anemia and vague symptoms of tiredness, lethargy, and breathlessness with a mass in the right ilia fossa must be investigated without delay. Okay, there are few causes that can cause this type of symptoms. Normally, carcinoma of the stomach, carcinoma of the cecum, and also carcinoma in other parts of the intestine as well. So a quick investigation and diagnosis is vital for early detection and improved survival. Thank you, and hope to see you again in another session.